So, as I said, LAM's a pretty rare disease. The prevalence in most populations studied is about 5 per million actually women rather than the whole population. For sporadic LAM, if you look at tuberous sclerosis LAM, as I say, it's much more common. So tuberous sclerosis is a rare disease. It's about 1 in 6,000 people born have tuberous sclerosis. So it's rare, but it's not rare as LAM. And if you look at adult women, about 10% of them by the age of 20 will have some signs of LAM, and by the age of 40 it's about 80%. Most of those don't have much in the way of symptoms, or in fact any symptoms, but it's actually quite common if you have tuberous sclerosis to get LAM. So one of the very odd things about LAM is that it really only affects women. And it's one of the most female-ly restricted diseases, much more than, say, breast cancer, which affects men much more than LAM would. We don't really know why this is, but we think it's something to do with the female hormone estrogen. If you look at men with tuberous sclerosis, a few of them get lung cysts that look like LAM, but it doesn't turn into a sort of a problem. They don't get lots of them. They don't get the breathlessness or the pneumothorax particularly. And we think this is because LAM cells are responsive to estrogen. Estrogen is the main female hormone. If you take LAM cells in the laboratory and you grow them in a dish, if you add estrogen, they grow faster. If you put them into model systems, they tend to spread around more and misbehave more if you give them estrogen. And so we think that it's women's estrogen levels that are probably the thing that drives LAM, in addition to the cellular change that everybody needs to have first. So we think that if you're prone to get LAM, more estrogen probably makes LAM worse. So we tell women with LAM not to take estrogen-containing treatments, like the combined contraceptive pill, like hormone replacement therapy once they're postmenopausal. I'm going to use a magic thing here. Look, if the other thing that's bad for LAM is pregnancy. Sometimes your estrogen levels rise during pregnancy, and at this time you can sometimes have more complications of LAM, probably because of the estrogen. And when your natural estrogen level falls after the menopause, the rate of progression of LAM on average tends to slow down. So all of this evidence suggests that LAM's an estrogen-driven disease, which is why it affects women particularly. So what type of disease is LAM? It's a fairly unusual type of disease. What happens in LAM is that an abnormal type of cell that has a change in its genetic makeup it is allowed to grow and grows towards the lymphatic tissue, towards the lungs, and sometimes towards the kidneys. And these abnormal LAM cells build up in the lungs, lymphatics, and kidneys. And the cells, they don't have an off switch. Normal cells, when you have enough of them in an organ, they just stop growing, and they do their function. If they die, then they're replaced. LAM cells don't have the off switch. They just keep growing, and as they build up, and they do this at different rates, but then they sort of get in the way and cause damage within the organ. And this, affecting the lungs, causes most of the lung damage, causing the collapsed lungs and the blockage of the lymphatic system that allows this chylous fluid to build up around the lungs and in the abdomen sometimes. And all of this causes breathlessness. So this is a CT scan of someone with LAM. There's a bit more on CT scans later on. But most people, the penny drops with their doctor that they might have LAM when they end up having a CT scan, and you see these little cysts in the lungs. So just to sort of orientate you, this is the person's back. So this is their backbone, their spine. Big thing in the middle is the heart, and these grey areas are the lungs, and the little things highlighted by the arrows, the little round black cysts, which I hope you can see. They're the thing that's characteristic of LAM. And so it's usually when someone has a CT scan for a respiratory problem, the doctors will see these cysts and they'll think of LAM in women particularly. So I'm going to talk a little bit about the problems that LAM causes now. So Pneumothorax is perhaps one of the most common problems with LAM. It affects about 3/4 of women with LAM. So most people will have at least one pneumothorax at some point in their illness. And a pneumothorax occurs when one of the cysts leaks air outside the lung and the lung's allowed to collapse down. So this is an ordinary chest X-ray of somebody with LAM. This is the left lung here, and you can see that you can see little lung markings in between the ribs. The left lung is all inflated. On the right side, it looks much darker. That's because there's no lung here. It's all collapsed down, and the whole lung is this little thing here. So that's a complete pneumothorax. And this, as I say, happens when the cysts leak air around the lung, and the lung's held up by a vacuum. And when air gets into it, it collapses down. Anybody can get pneumothorax. For women with LAM that get pneumothorax, it's often more difficult to treat than people without an underlying lung condition. Sometimes you need surgery. And this little cartoon just shows you what we normally do, and probably some of you know only too well what happens. So this is the expanded lung here. This is the collapsed one, and then there's this air space in between the chest wall and the lung, and the air's got out through this little ruptured cyst here, and usually a chest drain, which is a plastic tube, is placed between the ribs to drain the air out of the space, allowing the lung to expand. But as I say, sometimes you need surgery for that. So this is a common problem for women with LAM. If you have lots of episodes of pneumothorax, then we usually recommend that you have an operation called a pleurodesis or pleurectomy to prevent that happening in the future. This is a much rarer problem. This is a chylous effusion. So chyle is the fluid that is normally running around in your lymphatic channels. And as I said, the LAM cells can block the lymphatic system, and that causes the fluid to leak out sometimes. And here, this white patch at the bottom of the lung here is actually chylous fluid, not in the lung, but around it. And it sort of just stops the lung from expanding quite so much. And so this usually causes breathlessness. You can get build-up of chylous fluid in the chest, or sometimes in the abdomen as well. And this is quite a rare complication. This is another CT scan. And what we're looking at here is the pelvis. So we're taking a section about this high up. So these things are the hip joints here. This is the bladder. And this sort of oval thing is a enlarged lymphatic. Very often people don't know these are there at all because there's lots of room in your abdomen. If you know, this is only a few centimetres, it looks big in the picture. This one's pressing on the bladder, so it might cause symptoms. These happen in about 10% of people with LAM. When we see people for the first time, we usually get a CT scan of their abdomen to see if they have these types of problems. About 2/3 of people have very slight enlargement of their lymphatic channels in the abdomen, and only about 10 to 20 will have one of these big ones, and most of them don't cause any symptoms at all. Occasionally they cause symptoms such as bloating that gets worse through the day. And actually, if you speak to women with LAM who have these things, quite often somebody will say, oh, well, I was told I had irritable bowel syndrome a few years ago. And actually, it probably wasn't that. It was probably a bit of lymphatic disease. Obviously, irritable bowel syndrome is very common. This is very unusual. And so, like a lot of features in LAM, it gets mistaken for other things first off. And these are called lymphangioliomyomas, these lymphatic collections. So this is quite a common thing. About half of women with LAM will have something called an angiomyolipoma. Now this is a benign tumour. They usually occur in the kidneys, and because they're benign, they don't really cause any particular problems for the majority of people. So this is another CT scan here. This time we're this high up. That's the backbone, that's the kidney, and the tumour is this thing here, this little round blob. That's probably, I don't know, 12 millimetres or something. That will never cause any symptoms. It's just there, but they're quite a common feature of women with LAM. And if we see those in somebody with lung cysts, the association of the angiomyolipoma and the lung cysts usually makes the diagnosis secure. We don't need to do any other tests to prove you have LAM if you've got one of these things, because like the lung problem, these are quite rare too. So the problem with angiomyolipomas is that sometimes they can get quite large, and the large ones are more prone to bleeding. And the little ones like this never cause any trouble. But it's worth knowing that you have an angiomyolipoma, because they're present in about half of women with LAM. Nearly everybody with tuberous sclerosis-related LAM has angiomyolipomas. As I say, most of them are small, but the big ones can bleed, and so whenever we see somebody for the first time, we get a scan of the abdomen to look for the lymphatic complications and also to see if people have angiomyolipoma. So it helps us with the diagnosis, and then sometimes we find things that might need treating. So the first symptoms that people get with LAM tend to be either pneumothorax, which is this slice of the pie chart, or breathlessness. These are the most common things. And you know, if you talk to a lot of people who maybe know a little bit about LAM, they'll say, oh yes, it's all young women and they all have pneumothorax. Actually, now we do more CT scans and we know more about LAM. As the years have gone by, we see that the sort of people who we identify with LAM are sort of changing a little bit, really. We're seeing LAM in older people. So this is from all the old papers about LAM that sort of go back to the sort of 1980s and things. This is a collection of how people present. This was from the a big American registry that published about 10 years ago now. And you can see that actually more people were presenting with other respiratory symptoms than the standard pneumothorax and breathlessness. And what's happening now is that in the old days, you know, it was very hard to get a CT scan. Nobody really did them. They were expensive tests. There weren't many scanners. Now every hospital's got several scanners, and everybody's always having a CT scan for any symptom. And so we're diagnosing LAM in a much wider range of people, and these are the people that we look after at the LAM Centre, or a selection of them. And you can see that non-respiratory problems are actually quite a common first symptom. So I've got people who had a car accident and they had a whole body scan to see if they had trauma, and it turned out they had LAM. It wasn't anything to do with their car accident. They had no symptoms beforehand. People who have gynecological problems get a scan for that. You catch sight of their lungs, you see a few cysts, and then they end up getting diagnosed with LAM. And that's quite common. And actually a lot of these people don't have symptoms, and they're older now, sort of nearly 50 look, and compared with mid-30s. So we recognise LAM in lots of women now. It seems to explain things in a much wider context than we used to think was likely. So what symptoms do you get with LAM? Well, as I've said, in the people that we identify maybe by accident, there may be none. People with tuberous sclerosis and mild disease may have no lung symptoms. The most common symptom that women with LAM have is breathlessness. Most women have some degree of this. It's very variable. It might be when they might be more breathless than they feel they should be when they do exercise, or they might be breathless walking on the flat, or they might be breathless doing household tasks. There's a whole spectrum. This is the most common symptom. Some people get a bit of airway narrowing, get wheezy. Some people have chest pain, and pneumothorax is certainly a cause of chest pain. And sometimes the surgery that you need to treat difficult pneumothorax is associated with chest pain. Cough is reasonably common. People are a bit prone to infections sometimes and have cough quite often. Some people cough up very small amounts of blood or this lymphatic fluid even. That's less common, but cough's a symptom sometimes. As I've said, the lymphatic disease in the abdomen can sometimes cause bloating and abdominal swelling. That's not usually severe, but it's a sort of bit of a nuisance sometimes. And actually, probably the second most common symptom, if you survey everybody, is fatigue, feeling more tired than you would expect compared with what you've normally done in the day. It's quite a hard thing to to assess, really. I mean, quite a lot of women with LAM, they're in their 30s, they often have young children and a job, and they're all very busy, and so it's hard to say whether the fatigue's always due to LAM, but on average, if you ask everybody, they seem to have higher levels of fatigue than people without LAM. Tricky thing is, of course, is that if you look at all of these symptoms, lots of diseases can cause breathlessness or cough or a feeling of tiredness or bloating, and so it very often takes a long time for LAM to get diagnosed. Now we do more CT, it's getting faster, but when we looked previously, the average time from first symptom to being told that you had LAM was 4.5 years for most people. And of course that's very difficult because most people know there's something going on, but you've got asthma or you just had a spontaneous pneumothorax. It's quite common. All of those, asthma and spontaneous pneumothorax are fairly common. But actually, you usually know that there's something else going on, and it often takes a long time for the penny to drop, and that's often difficult for people. So what happens as time goes by? For most women with LAM, lung function falls a little faster than in the normal population. So these lines are the lung function tests, and there's more on lung function later on this morning, so I'm not going to talk about this a lot. These lines are lung function tests in people with LAM that we look after, and this is a sort of average slope here, and so they fall gradually as time goes by. Now we have a treatment, rapamycin, that can stabilise the disease. Actually, I think this has moved a bit. This average bar should probably be up here. But now we have a treatment that we can usually stabilise loss of lung function. So if you're one of the people whose lung function's falling, then we have a treatment to offer you to try and stabilise that now. And that's rapamycin. If we look at how quickly this particular measure of lung function falls in this particular study that we did, for people on no treatment, the FEV1 falls at about 70 millilitres a year, which is about 3 times faster than normal. If we put people on rapamycin, it's actually levels out pretty much completely. So we have an effective treatment now. And so as time goes by, we follow people's lung function, and if it looks like they're changing, then we have a treatment to offer them now. These are some quite old slides now about symptoms, and what you have to bear in mind is when we did all this, there was no rapamycin, really no effective treatment for LAM, and so these slides don't completely apply now to people, but this is these lines here show how long it takes for people to get to different levels of symptoms. So and this is something called the MRC dyspnea score, so it's a grade of breathlessness, really. So if you walk slower than your friends on flat ground, which is grade 3 dyspnea, because you're limited by breathlessness, the line goes sort of down a little bit. This is short of breath when hurrying, this is too breathless to leave the house. So the graphs show, so if this is when you have your first symptom, if you look at what happens after 10 years, if you don't treat people, probably about half of them, and we didn't treat them not because we wanted to find out what happened, but because we didn't have a treatment, about half of them by that time have to walk more slowly than their friends of the same age, or they have to stop on the flat. About sort of 5% are too breathless to leave the house. Obviously, as I say, we have a treatment now, so these figures have improved. And everybody asks or wants to ask about survival. The figures are very muddly. If you read an old book, it'll say 10 years or 4 years from diagnosis, or some totally wrong thing, and you still see people that come to see you for the first time and they think this is what's going to happen. Actually, the best estimate is probably the median survival is probably 29 years from your first symptom. This is actually also before rapamycin. So actually it's going to take us another 29 years to see how much it's improved. But actually the outcome for LAM is much better than in old books and all of these sorts of things. So I mean these are the untreated figures now. So how should we monitor people as time goes by? Just got 5 minutes, just going to speed up a little bit. We think we should have a medical review. If things are very stable, that might just need to be once a year. Or sometimes if we're trying to make a treatment decision, we'll see people more frequently, maybe 3 or 4 times a year. We'll check their lung function each time they come. And if they've got one of those angiomyolipomas, one of these little tumours in the kidneys, we usually get a scan of the kidneys, usually about once a year now. We know that the small tumours, this is how much they grow and this is how big they are. The small tumours hardly change in size at all. The bigger ones sometimes grow a little unpredictably. So if you have a bigger angiomyolipoma, we'll scan it regularly, and if it needs something doing, we'll ask a specialist to see you about that. And then there's as required things. So if you have pneumothorax or if you have infections, obviously you might need a medical intervention for that. And what should happen is that there should be some sort of plan and about what to do if you get symptoms of pneumothorax. Your GP should be on side with treating you promptly for chest infections with antibiotics. Should I have drug treatment for LAM? Just briefly, I'm going to talk about bronchodilators later. So there's types of inhalers that people use for asthma are helpful for some women with LAM, and they might help breathlessness. So I'm not going to spend much time on this because we're talking about it later. There's this drug rapamycin which reduces decline in lung function. It makes the angiomyolipomas smaller. It's helpful for lymphatic complications. If you've got pretty normal lung function that's not changing and very few symptoms, you may not need to take rapamycin at all. For people with progressive disease or difficult problems in other areas, then we use the rapamycin frequently now. There's lots of research going on in different places to see if drugs might be better. Certain drugs might be either better than rapamycin, such as saracatinib, and then there are drugs that you can add into rapamycin to get more benefit. And so the statin drugs theoretically might improve the response to rapamycin in some patients. Same with chloroquine, same with metformin, which is actually a drug that we usually use to treat diabetes. So all of these are being tested at the moment. We don't know the results yet. We used to block estrogen in different ways for LAM in the old days. For most people, that's not an effective therapy. We don't really do that anymore. There was a vogue for treating people with doxycycline to try and block lung damage, and I spent a very long time doing a trial, unfortunately showing that wasn't effective. So we don't use that anymore. We still take it as an antibiotic, but so it's no longer thought to be helpful for LAM. So what else can you do about your LAM? We usually recommend that people know what to do if they get symptoms of pneumothorax or problems with their kidney tumours. We usually tell them to get vaccinated against influenza and pneumonia, and which your GP can do for you. We warn them that pregnancy might be more complicated, and in the old days people said, oh, you just can't be pregnant if you have LAM. That's not true, but it is best to talk through your particular case with your LAM doctor if you're thinking about becoming pregnant, so we get a proper plan and we can give you the right advice. We advise people to keep fit and as active as they can. And we tell people it's not sensible to take estrogen in the forms of hormone replacement after menopause or in the contraceptive pill. The progesterone-only pill's okay, but the estrogen one isn't. And smoking's not really a good idea for anybody, so we discourage that. And the only other advice we have really, I suppose, is we suggest we don't let chest infections drag on. We have a sort of lower threshold for using antibiotics. And we again, so you should see your doctor urgently or go to A&E if you think you might have had a collapsed lung or other acute symptoms. And as I say, it's sensible to discuss pregnancy before starting